When we think about how our bodies work, we usually imagine this incredibly precise, um, beautifully organized
Oh,
machine.
absolutely. Like a Swiss watch.
Right. And for a lot of our nervous system, that is actually true. Take the peripheral autonomic nervous system, the part that automatically manages your heart rate or, your digestion. It essentially runs on just two primary chemical messengers.
Acetylcholine and norepinephrine.
Exactly. Just two. It's like a massive corporation being run by two extremely efficient managers. But then you look at the central nervous system, the brain, and the spinal cord, and suddenly that simplicity just, well, it vanishes completely.
It really does. It's a completely different world in there.
The central nervous system uses anywhere from 10 to perhaps 50 different neurotransmitters. We want to explore this staggeringly complex mission, which is how modern medicine chemically treats the decaying infrastructure of the brain.
Yeah, we're focusing on neurodegenerative diseases here. So specifically Parkinson's, Alzheimer's, multiple sclerosis, and ALS.
And it is a lot to cover.
It is, but the jump in complexity from the peripheral to the central nervous system, it really cannot be overstated. If the peripheral nervous system is a quiet, well-organized two-lane highway, the central nervous system is more like the air traffic control network of a major international airport during like a Category 5 hurricane.
Wow. Okay, that's a stressful image.
Right, because you have billions of neurons making trillions of synapses with dozens of different chemical messengers all trying to manage the chaos simultaneously. And the crucial thing to understand right from the start of these clinical texts is that the drugs we're going to discuss, they don't cure these diseases.
They don't fix the underlying problem.
No, they cannot rebuild the crumbling control towers. Instead, they act more like emergency traffic cops, biological decoys, and cellular bouncers. They're just trying to restore some semblance of order in a system that is fundamentally degrading.
Okay, let's unpack this. Because before we can understand how these incredible pharmacological tools step in to fix the brain, we really have to understand how the brain's signals get crossed in the first place.
Yeah, we have to look at the baseline.
Right. And instead of getting bogged down in the exact cellular math and, the heavy terminology of electrical depolarization, it helped me to think of every single neuron as a sort of microscopic polling station.
I actually love that analogy. It's a highly accurate way to conceptualize it. The communication between neurons relies on chemical messengers that are essentially casting votes. We call these synaptic potentials.
And there are two types of votes, right?
Exactly. You have excitatory neurotransmitters like glutamate or acetylcholine, which act as the yes votes. They bind to the neuron and open up specific channels, usually letting sodium in, which pushes the neuron closer to action.
So if a neuron collects enough of those yes votes, it reaches its threshold and basically fires an electrical impulse.
Yes, it fires. But you obviously can't have your nervous system firing uncontrollably all the time.
Right, that would be chaos. You need a way to veto the action.
And those are the no votes. Inhibitory neurotransmitters like GABA or in certain brain regions, dopamine, they open different channels. They might let negatively charged chloride ions in, which actually pulls the neuron away from that firing threshold.
Oh, I see. It makes it much harder for the nerve to fire.
Exactly.
Yeah.
So a healthy central nervous system is just a flawless, constant counting of millions of yes and no votes.
Which brings us to Parkinson's disease, because in Parkinson's, that flawless voting system is completely broken. The medical texts detail how the disease is characterized by the destruction of a very specific group of neurons in a part of the brain called the substantia nigra,
Right, the dopaminergic neurons.
meaning they produce and secrete dopamine. And their job normally is to send dopamine over to another area called the neostriatum to act as a steady stream of no votes.
Yeah, they provide a constant baseline of inhibition.
Meanwhile, you have cholinergic neurons in that exact same area secreting acetylcholine, which provides the excitatory yes votes.
Yeah.
So you have this delicate balance, right? Dopamine inhibiting, acetylcholine exciting.
But in Parkinson's, those dopamine-producing neurons progressively die off.
So the inhibition just disappears. The no votes are gone. It's like driving a car where the acetylcholine is a stuck accelerator pedal and the dopamine is the brake. Parkinson's basically removes the brake so the acetylcholine just runs completely wild.
Yeah, you have this massive overproduction of excitatory signaling.
And that overactivity is what triggers the characteristic symptoms of Parkinson's, right? The resting tremors, the severe muscular rigidity, and bradykinesia, which is that extreme, frustrating slowness when a patient tries to initiate a movement. The car is shanking and lurching because the accelerator is pinned and the brakes have been cut.
That's spot on. The strategy for treatment, then, becomes fairly straightforward in theory. We need to restore the dopamine or block the acetylcholine to fix the balance.
Now, reading through the pharmacology texts, an obvious question jumps out. If the brain desperately needs dopamine, why go through all this complex biochemical engineering? Like, why can't a patient just swallow a capsule of dopamine?
It's a fair question, but it hits a major physiological brick wall, which is the blood-brain barrier. The brain is incredibly selective about what it lets in from the bloodstream, to protect itself from toxins and pathogens.
It's a highly secure VIP area.
Exactly. And dopamine physically cannot cross that barrier. If you take a dopamine pill, it will just circulate in your blood, cause massive issues in your peripheral body, and absolutely none of it will reach the substantia nigra where the brain actually needs it.
So the medical community had to develop a Trojan horse.
And that Trojan horse is a drug called levodopa. Levodopa is a metabolic precursor to dopamine. Unlike dopamine itself, levodopa is actually recognized by the brain's active transport mechanisms.
Oh, so it has a VIP pass.
Right. It gets escorted right across the blood-brain barrier. Once it sneaks inside the central nervous system, the surviving neurons take it up and use an enzyme to convert it directly into the dopamine the brain so desperately needs.
Wait, I have to push back on the logic here a bit. If we're pumping the patient's body full of levodopa to turn into dopamine, aren't we just indiscriminately flooding the entire central nervous system? I mean, there are perfectly healthy areas of the brain that use dopamine too. Doesn't flooding the system cause its own massive set of neurological problems?
That is a critical observation, and the clinical data bears that out entirely. Over time, that nonspecific flooding can cause severe dyskinesias. Those are involuntary, erratic movements, along with psychiatric side effects like hallucinations.
Wow, that sounds awful.
It is. But the more immediate crisis when administering levodopa isn't actually in the brain at all, it's in the peripheral body.
Yeah.
Your peripheral tissues are packed with enzymes that will eagerly convert that levodopa into dopamine right there in your gut and your bloodstream, long before it ever reaches the brain.
And dopamine out in the periphery causes severe nausea, vomiting, cardiac arrhythmias, and drops in blood pressure.
Exactly.
So to get enough levodopa into the brain to actually relieve the Parkinson's symptoms, you'd have to give such a massive oral dose that those peripheral side effects become just intolerable. If the drug is being destroyed in the gut, we'd almost need a secondary drug to run interference, right?
What's fascinating here is the pharmacological solution they found. It's a drug called carbidopa. It inhibits the enzyme responsible for breaking down levodopa in the periphery. But the defining feature of carbidopa is that it cannot cross the blood-brain barrier itself.
Oh, so it acts as a bodyguard?
A bodyguard that stays strictly on the outside. It fights off the enzymes in the peripheral bloodstream, preventing the levodopa from being metabolized in the gut. This allows a massive amount of intact levodopa to safely reach the blood-brain barrier and cross over.
That's incredibly clever.
It really is. By co-administering carbidopa, clinicians can lower the required dose of levodopa by 4- to 5-fold, which drastically reduces those terrible peripheral side effects like the racing heart and severe nausea.
One of the pharmacological papers we reviewed highlighted a really counterintuitive detail about taking these two drugs, though. If you or someone you know is on levodopa, you actually have to be incredibly careful about your diet. You shouldn't take it with a high-protein meal.
Right, the steak dinner problem.
Yeah, because protein is broken down into neutral amino acids, like leucine. And those neutral amino acids use the exact same transport system to cross the gut wall and the blood-brain barrier as the levodopa does. They basically compete for the exact same door.
Exactly.
If you eat a massive steak, those amino acids crowd the doorway and the levodopa just gets left outside. The drug effect diminishes significantly.
It really illustrates how a simple dietary choice can directly alter a complex neurological treatment. But, even with the perfect diet and the carbidopa bodyguard, levodopa is not a permanent fix. Parkinson's is fundamentally degenerative.
Right. It keeps getting worse.
Yeah. As the years go on, more and more of those dopaminergic neurons die. Eventually, there just aren't enough surviving neurons left to take up the levodopa, convert it, and store it for later use.
So the storage capacity shrinks, leading to what the texts call the wearing off phenomenon. The therapeutic window gets tighter and tighter, and patients start fluctuating rapidly between good mobility and severe rigidity.
It's a very difficult phase of the disease.
So if the levodopa strategy starts losing its effectiveness, the next logical step is protecting whatever natural dopamine the patient still has, right? And the pharmacology world tackled this with enzyme blockers.
Yes. We use MAOB inhibitors, like selegiline or rasagiline. These specifically inhibit the enzyme monoamine oxidase type B, which naturally metabolizes and clears away dopamine in the brain.
Oh, so by blocking the brain's own garbage collectors, you leave the dopamine in the synapse longer.
Precisely. We also use COMT inhibitors, which stop a completely different degradation pathway to stretch that dopamine even further.
Looking at the clinical data for these COMT inhibitors, there's a rather dramatic warning about an older one called tolcapone. It's a highly effective drug for increasing the central uptake of levodopa, but it carries a terrifying risk, which is fulminating hepatic necrosis.
Yeah. Severe sudden liver failure.
Because of that, tolcapone is rarely used today, right?
Yeah.
Only as an absolute last resort, and it has largely been replaced by a much safer COMT inhibitor called entacapone.
It's a constant risk-reward calculation in medicine. Sometimes a drug works flawlessly in the neural architecture, but proves catastrophically toxic to another organ system. That happens, pharmacology just has to pivot.
Right.
Another strategy to delay the need for levodopa entirely in early Parkinson's is the use of dopamine agonists. Drugs like ropinirole or rotigotine, which actually comes as a once-daily transdermal patch.
Oh, a patch. That's convenient.
Yeah, and they don't need to be converted at all. They just directly stimulate the dopamine receptors, basically mimicking the missing neurotransmitter.
But perhaps the most surprising drug in the anti-Parkinson's arsenal is one that wasn't designed for the brain at all, amantadine. This is an antiviral drug originally used to treat influenza, but somehow it was discovered to improve Parkinson's symptoms. How does an antiviral flu medicine help a movement disorder?
Pure serendipity, honestly. It turns out amantadine has secondary mechanisms of action that have absolutely nothing to do with fighting viruses.
Wait, really?
Yeah, it alters the release of dopamine, blocks certain cholinergic receptors, and it inhibits a specific type of glutamate receptor called the NMDA receptor. Tweaking these secondary pathways provides real relief for Parkinson's rigidity, which just goes to show how accidental discoveries often drive medical progress.
That is so wild. We've seen how devastating it is when the brain loses the dopamine needed to orchestrate physical movement. But the tragedy of neurodegeneration is that it doesn't just steal our mobility, it targets our identity. When the chemical deficits shift from dopamine to acetylcholine, we aren't losing movement, we're losing memory.
Which brings us to Alzheimer's disease. In Alzheimer's, the neurodegeneration targets the cortex and the basal forebrain. It's characterized by the profound loss of cholinergic neurons, the ones that use acetylcholine, which is vital for memory formation. We also see the physical accumulation of senile plaques made of beta-amyloid protein and neurofibrillary tangles inside the cells.
And we should set expectations here. Current pharmacological intervention for Alzheimer's is strictly palliative, right?
Yes. It provides modest short-term benefits, but it does not halt the underlying cellular death.
Since the immediate problem is a progressive loss of acetylcholine, the first line of defense detailed in the research is acetylcholinesterase inhibitors, drugs like donepezil and rivastigmine. This is very similar to the enzyme blockers we saw in Parkinson's.
Exactly the same principle.
If acetylcholine is disappearing, we stop the body from naturally breaking down whatever acetylcholine is left. We keep those memory-forming signals active in the synapse for as long as possible. But there's a second, much darker mechanism at play in Alzheimer's called excitotoxicity.
And this brings us right back to the excitatory yes votes we discussed at the very beginning. Glutamate is the primary excitatory neurotransmitter in the brain. It is essential for learning. But in Alzheimer's, as cells get sick and start dying, there's a pathological overstimulation of those glutamate receptors, specifically the NMDA receptors.
Okay, and what happens when they get overstimulated?
When those receptors are overstimulated, they stay open way too long, and they let massive, unregulated amounts of calcium rush into the neuron.
Now, a little calcium is necessary for the cell to function, right?
Yes, a little is fine.
But a massive flood of calcium is toxic. It activates enzymes that literally digest the neuron from the inside out. It's cell death by overexcitement, excitotoxicity.
It's a brutal process.
And to combat this, the clinical texts introduce a drug called memantine, which is an NMDA receptor antagonist. The mechanism for memantine is fascinating. It acts like a highly trained bouncer at the door of a nightclub.
A bouncer. I like that.
Yeah, so the nightclub is the neuron, and the door is the NMDA receptor. During that toxic overstimulation, a massive, unruly mob of calcium tries to rush the door. Memantine steps in, physically blocks the channel and stops the toxic mob from getting in and destroying the club, but it doesn't permanently lock and board up the door.
Right, it can't do that.
It still allows the regular, well-behaved calcium ions to trickle in because the club still needs some patrons to survive.
That selective blockade is the true genius of memantine. If you completely block the NMDA channel, you would induce the effects of psychoactive drugs like phencyclidine PCP.
Oh, wow. PCP.
Yeah, complete blockade causes severe cognitive disruption, hallucinations, and coma. Memantine only shaves off the toxic peak of the calcium influx while preserving the vital baseline flow of ions needed for regular cellular function.
Incredible. So far, with Parkinson's and Alzheimer's, we've been exploring chemical imbalances in the synapses. Not enough dopamine, too much glutamate. But what happens when the actual physical structure, the wiring of the nervous system, is being destroyed?
That brings us to multiple sclerosis and ALS.
Right.
In multiple sclerosis, or MS, we're dealing with an autoimmune inflammatory disease. The body's own immune system gets confused and starts actively attacking the myelin sheath. The myelin is the protective, insulating layer wrapped around the axons of neurons.
Like the rubber insulation on a copper wire?
Exactly. Without it, the electrical signals slow down, short circuit, or just stop altogether, leading to profound sensory and motor deficits.
And the pharmacological approach in these papers completely shifts here. We aren't tweaking neurotransmitters to balance a seesaw anymore. We are actively trying to trick the immune system.
Yes, it's a completely different battlefield.
Take glatiramer. It's a synthetic polypeptide. How does this actually intercept an autoimmune attack?
Well, the immune system has aggressive T cells circulating, incorrectly looking for myelin to destroy. Glatiramer is engineered to chemically resemble myelin basic protein. By injecting it into the patient, you basically flood the system with decoy targets.
So the immune system gets distracted.
Exactly. The aggressive T cells bind to the glatiramer instead of the actual myelin in the central nervous system. You're essentially giving the immune system a false war to fight, absorbing the damage to spare the actual nerves.
It's just biological misdirection. But another drug, fingolimod, takes a completely different route. The research details how it traps the immune cells rather than tricking them.
Right. Fingolimod is an oral drug that alters lymphocyte migration. T cells, those aggressive white blood cells, are housed in lymph nodes. They require a specific chemical signal to leave the lymph node and enter the bloodstream to patrol the body.
Okay, so they need orders to deploy.
Yeah, and fingolimod essentially jams that signal. The lymphocytes get sequestered inside the lymph nodes. They remain perfectly healthy, but they're trapped in the barracks and literally cannot travel to the brain and spinal cord to cause that demyelination.
That is brilliant. Moving from MS to ALS, amyotrophic lateral sclerosis, the clinical texts are pretty grim here, focusing on the progressive, fatal death of actual motor neurons.
It is a devastating disease. The mechanism is incredibly complex, likely involving a combination of oxidative stress and the exact same glutamate excitotoxicity we saw in Alzheimer's. The primary drug highlighted for ALS is riluzole.
Another NMDA receptor antagonist. But how does dampening glutamate actually buy time for an ALS patient facing motor neuron death?
Riluzole takes a multi-pronged approach to reduce the excitotoxic burden. It inhibits glutamate release, blocks voltage-dependent sodium channels, and interferes with the intracellular events that follow transmitter binding.
So it's fighting it from multiple angles.
Exactly. By aggressively dampening that excitatory transmission, it protects the surviving motor neurons just a little bit longer. It doesn't halt the disease, unfortunately, but it can extend a patient's survival time and delay the devastating point at which they require a mechanical ventilator to breathe.
Think about the immense ingenuity in the journey we just took through these pharmacological papers. We have levodopa acting as a chemical Trojan horse, escorted past the gut by a bodyguard drug. We have an antiviral flu medication accidentally teaching us how to calm Parkinson's tremors. We have memantine acting as a selective bouncer to protect cells from toxic calcium mobs, synthetic decoys throwing false targets to the immune system, and drugs locking white blood cells in their barracks to save our nervous system's wiring.
If we connect this to the bigger picture, whether we're talking about demyelination in MS, motor neuron death in ALS, plaques in Alzheimer's, or the loss of dopamine in Parkinson's, the overarching pharmacological reality today is that we are managing symptoms.
Right, we're holding the line.
Exactly. We are protecting the surviving neurons and squeezing every last drop of function out of a compromised system. But we do not yet possess the tools to reverse the foundational neurodegeneration.
And as you're listening to this right now, processing these concepts, your own central nervous system is flawlessly juggling dozens of neurotransmitters, balancing millions of excitatory and inhibitory votes just to make sense of the audio. It is a terrifyingly delicate machine.
It really is a marvel.
Which leaves us with a final provocative thought to ponder. All these brilliant drugs we analyze today, the decoys, the bouncers, the symptom maskers, are ultimately highly sophisticated band-aids. We are manipulating the downstream chemistry just to buy time.
That's the reality of where we are right now.
But if human ingenuity can engineer solutions this intricate just to manage the symptoms, what kind of unimaginable medical revolution is waiting for us when we finally discover the unidentified environmental or genetic triggers that cause these neurons to start dying in the very first place? When we finally stop trading the smoke and learn how to put out the fire?